Hi, everyone. I'm just going to give it another minute or so before we get started so we can give everyone time to join. Hi, everyone. Welcome to today's webinar. My name is Maggie Nicholas Alexander, and I'm the Senior Director of Gynecologic Cancer Patient Support and Education at Share Cancer Support. Thank you for joining us today. This program is being put on in partnership between Memorial Sloan Kettering Cancer Center and Share. Before the program begins, I'd like to tell you a little bit about MSK's Office of Health Equity and Share. MSK's Office of Health Equity was established to address disparities in cancer outcomes based on race, ethnicity, cultural differences, and socioeconomic status. The Office of Health Equity has three core areas of focus: patient access, research, and training. Learn more at msk.org. Share is a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with women's cancers and provides outreach to the general public about signs and symptoms, because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information, please visit our website at sharecancersupport.org. A special thanks to everyone who is joining us today. We appreciate you taking the time to learn more about family health history and the connection to cancer. This webinar is being recorded and will be available on the MSK and Share website soon. Now, before we get started, we would like to learn a little bit more about you, our audience. So we ask that you take a moment to answer the poll questions, which are going to pop up shortly. Looking forward to seeing the results and who we have with us today. We'll give it just a little bit more time. Okay. All right. So it looks like the majority of you joining us today, 88%, are a patient. We also have some family members who are joining us, as well as some healthcare providers, but by far most of you are patients. So we're so glad to have this conversation with you today. And then also, it looks like a lot of you have heard about family health history before. So that's a great starting point, and we're going to really delve into this topic today. So thank you for participating in our poll. And now we're going to get started with the conversation. So I'm just going to briefly introduce our panelists. And so we have Dr. Ying Liu joining us, Dr. Tracy-Ann Moo, and Nefa-Tari Moore and joining us. And we'll be hearing from Nefa-Tari a little later, but Dr. Liu and Dr. Moo, I don't know if you want to say something briefly to help the audience get acquainted with you before we delve into the conversation. So I'll start with you, Dr. Liu.
Sure. Thank you so much for having me tonight. So I am a medical oncologist and I see patients with GYN cancers like uterine and ovarian cancers. And I also practice in our genetics clinic. So I help counsel patients and their families about the importance of genetic testing and how to prevent these cancers. So it's really timely and great to be here tonight.
Great, thank you. And Dr. Moo?
Hi, I'm Tracy-Ann Moo. As Maggie mentioned, I'm a breast surgeon here at MSK, and I treat women who are diagnosed with breast cancer, taking care of the surgical part of things. Of course, I work with our medical oncologists like Dr. Liu on breast cancer. So I'm a part of the team that takes care of breast cancer here.
Great, thank you. Thank you so much for joining our program today and sharing your expertise with us. So I think we're just gonna go ahead and jump right in because I know we have a lot to get through. So Dr. Liu, this first question, I'm gonna direct it to you, but of course throughout either of you can chime in or answer. So as we know, today's program is focused on family health history and the connection to cancer. Could you explain a little bit more about what that is?
Yeah, absolutely. So we've known for a long time that diseases like cancer run in the family, and so if you have parents, grandparents, aunts, and uncles with certain types of cancers, you may be at higher risk for those cancers. And we've learned in the last few decades that there may be genes that are connected to these cancers that run in families, and we're learning more and more about how to test for these genes, what they are, and that's a lot of what we do. And then once we've identified these families and these genes, we try to prevent the cancers that are associated with them. And that's where, surgeons like Dr. Moo are very helpful. And sometimes the genetic testing can also, affect how someone is treated for their cancer. So that's why learning about your family history and considering genetic testing is so important.
Great. And I'm wondering if you could just go a little further and talk about, who, because families can be very big. So, who should be included in that family history? What family members?
Yeah, absolutely. So the more you know, the better. Anything is very helpful. For example, when people come to talk to us in genetics, the counselors will sit down with you and we'll draw a pedigree, which is a kind of a fancy picture of your family tree. We'll talk about your mother, your grandmother, aunts and uncles, cousins, and depending on how big your family is, sometimes these are very big trees. Other times people are adopted or don't know much about one side of their family. So sometimes they're smaller trees, but whatever information you have is very helpful. And that all helps us put together a picture of your family history and helps us, determine what type of genetic testing, if any, you need and in what cancers you might be at risk for.
That makes sense. And so when you're looking at that, what kind of conditions and, diseases are you including, like, should you be including in that family history?
That's a great question. So, there are certain cancers that may be more likely to be genetic. Breast cancer is definitely a big one. It is the most common cancer in women, and a decent portion of breast cancer is what we call genetic and runs in families. Some of those are related to genes that people may have heard of, like BRCA1 or BRCA2. There's some newer genes that are kind of related to that, but there's also families with breast cancer where we're not sure what the gene is, but there are many members of the family with breast cancer. Other cancers that kind of go along with that and are related to our theme tonight are GYN cancers, like ovarian cancers, certain types of endometrial cancers. We're learning more about other types of cancers that affect not just women, so prostate cancer and then pancreatic cancer, and then other cancers like colon and certain GI cancers. There are definitely, we talk about this a lot, that genetics is important, but environment's also important. So there are some cancers like lung cancer that may be more related to environmental things like smoking. But even in these types of cancers, there may be a genetic component as well. So that's why when we take a family history, we do these pedigrees, we really do talk about all the different types of cancers. But you're right, Maggie, in that certain cancers like breast and ovarian may trigger us to think more about a genetic syndrome and genetic testing.
Great, thank you. And, since we're going to be talking a lot about, genetics today, I'm wondering if you could just give a very brief, high-level overview of, what we're talking about in terms of genes and how they're inherited so the audience can have that understanding.
Sure, absolutely. I'll take us all back to high school biology. Just to kind of simplify things, what I tell people is that genes are like like spelling out a word, right? So genes are, the letters, and then what they do is they make proteins, which is like a sentence. So the words don't mean much, but when you put them together in a sentence, they have meanings. So genes make proteins that do things. And when your spelling isn't correct, you're not spelling the right word and the sentence doesn't make sense. So that protein is not doing its job. And that's what we're testing for. We test for the spelling, and we want to make sure your genes are spelled right, meaning that they can do what they're supposed to do. And when we find a mistake in the gene, we call that a mutation. And that usually means that it's not going to be working properly and not doing what it's supposed to do. And everyone, because genes are so important, everyone has 2 copies of every gene, one from their mom and one from their dad. And so that's kind of what we look for. And a lot of times with cancer, getting one mutated copy or one copy that's misspelled from one of your parents is enough to make the whole thing not work properly and put you at risk for cancer.
Great, thank you. I feel like it's helpful for us to have that basic understanding. Okay, so Dr. Moo, I'm going to pose this next question to you. I think we sort of started to get at it, but why is it important to know your family's health history?
Thanks, Maggie. So it's really important to know if possible, your family history, because that can inform how it informs your risk. So how we stratify you is what is your risk of, for example, in breast cancer, are you at average risk of getting breast cancer, or are you at high risk of getting breast cancer? And if you fall into that higher risk category, then we tend to screen you differently using different methodologies. So the average woman the woman with an average risk of breast cancer would get screened yearly with a mammogram and maybe an ultrasound as well, and a physical exam. But if you're at a higher risk, we may add an MRI to that once a year, and we may want you to have a breast exam twice a year rather than once a year. So it really informs how we our screening recommendations. So that's probably the more important part of knowing your family history, because it can affect your screening.
And so could you talk a little bit too about so screening and sort of what the goal of that is, and sort of also, how maybe it could give information that could help with prevention?
Right. So and to add, actually, to go back to add to tie into Dr. Liu, is it's also important to know your family history so that we know if we need to do genetic testing. So do we need to have you see somebody like Dr. Liu for her to look at your pedigree and do that genetic testing? So that's also another important reason why you should know your family history. In terms of how it ties into prevention and screening is important, because when you're screening, you're basically trying to find something before you develop a symptom, right? So before, in breast cancer, we'd say before you start feeling that mass in your breast, we can find the tumor when it's much smaller, more treatable, and you have a better prognosis. So that's why screening is important. So if we don't know how to screen for you, if we don't know that you're at a higher risk of getting a breast cancer, we're not going to be able to find that tiny breast cancer and treat it early, where your likelihood of doing well without having a lot more treatment is possible.
Great, thank you. And I think we started to talk about, some of the cancers that are, particularly impacted by family health history, but I'm wondering if there's any others that the audience should be aware of that haven't been mentioned yet.
No, I think we mentioned the big ones, breast cancer, ovarian cancer, pancreatic cancer, prostate cancer. There are changing recommendations all the time. And I know Maggie and the team are going to send out links to the NCCN, which are our national cancer guidelines that continually update these recommendations as we learn more. I will say we're learning more and more about cancers like colon cancer, endometrial cancer. These are interesting cancers because what we're seeing is that in certain cancers, we're seeing less and less. For example, lung cancer, less people are smoking, which is great. But other cancers like colon cancer and endometrial cancer, we're actually seeing more and more, and even more in young people. And some of that is genetic, some of that is environmental. So there are changing recommendations for a lot of these cancers. So I would say, definitely be aware of the big cancers we're talking about. But if there is a lot of cancer in your family, we're always happy to talk to you in our genetics clinic and kind of go through it with you. And sometimes we have patients come in who just want to talk about it. And at the end, we decide, you don't need genetic testing, and that can be helpful.
Great, thank you. And Dr. Liu, I know you sort of started to touch on this earlier in one of your answers, but what can a person do if their family health history isn't available to them?
Yeah, absolutely. So, there are still a lot of options because a lot of people don't know about their family health history. What little you do know is very helpful, but oftentimes we see people because they don't know they might be adopted and they want to have genetic testing at least to have some kind of understanding. And there's definitely ways to do that. I know a lot of people submitted questions about insurance and cost of genetic testing, which of course is a big issue. The costs have certainly gotten better as the technology has improved. Insurances are covering more and more. And Maggie, you're right, a lot of that depends on your family history. Sometimes we try to advocate for our patients. We say to them, the insurance companies, they don't know their family history and they deserve this opportunity. So we try to fight for that. There are also companies that offer very, reduced prices for genetic testing, reputable labs. So there are a lot of ways for a person to try to understand their quote unquote familial risks for cancers, even if they don't know about their family history.
Great, thank you for that. And then if certain cancers run in your family, is it likely that you'll also get cancer? I think sort of if you could talk a little bit about the idea of, risk factors and what that means, Dr. Liu.
Absolutely. It's not, nothing is 100% in life. So even if you carry the, BRCA gene, it doesn't mean you're definitely going to get breast cancer. It does mean that your risk is higher than the average woman. But like I said before, there's a combination of genetics and the environment, and there's a lot that people can do to reduce their risk. And that's part of what Dr. Moo and I try to do. We try to empower patients to, take ownership and understand that they are at high risk, but know that there's things that they can do, like the enhanced screening Dr. Moo was talking about, like, there are certain surgical procedures that can reduce your risk. There are lifestyle things, diet, exercise, certain types of medications. So even if there is cancer in your family, even if you have a gene that puts you at higher risk, it does not mean that you can't change your future, that you're going to get this cancer. In fact, a lot of what we do is we say knowledge is power. You might have this thing that you were born with, but knowing about it empowers you to make the changes that can actually prevent the cancer.
Great, thank you. And then on the flip side, Dr. Moo, can you still develop cancer even if you don't have that family history of cancer?
Yeah, so actually most of the answer is yes, in short, and for pretty much most of the cancers that I can think about. Dr. Liu, you can correct me if you think if you can think of one where it's 100%. But in breast particularly, most of the breast cancer, even though breast cancer, Dr. Liu said, is the most common cancer among women, and it probably has one of the higher percentages of having a hereditary link to it. Most of the breast cancer that we see is what we call sporadic. So it's not related to a gene that you're inherited from a family, from your parents. I think that number gets smaller when you start to include family history without a genetic mutation diagnosis per se, but yes, it's still possible to have breast cancer even if you don't have family members or if you don't have the gene.
And I'm guessing that's true for other
Yes.
cancers that have that hereditary component. All right, so now we're gonna sort of delve in more into the genetic testing. So Dr. Liu, I'm wondering if you could tell us a little bit about those tests that can be used to tell a person if they have an inherited genetic mutation linked to cancer.
Absolutely. No. So the process of genetic testing is a little bit complicated, and we try to make it as easy as possible. So it first starts with education and a conversation. So it first starts with just talking about your family history and deciding if you meet criteria for genetic testing, and that can depend on the cancers in your family, your own history, your age, and other factors, and then whether or not genetic testing is right for you. It's not. Sometimes it can be a very daunting experience, and so often I say it's worth a conversation just to come in, and sometimes we decide that it's not right for you at this moment, but at least it opens that door and makes that connection. If you do make the decision to do genetic testing and your provider thinks that you would benefit from it, you would meet criteria, there are a number of different tests. We've moved away from testing just one or two genes. Most of the testing done in the United States and around the world these days is with what we call multi-gene panels. So you send in one sample, which usually is either blood or a spit kit that you can mail. And they will test multiple genes, usually related to the cancers in your family, but that can include many different types of cancers. And then you'll get the results. Maggie, what I always tell people is that genetic testing is quirky, that instead of being straightforward and giving you, a yes or no, positive or negative, there's actually 3 categories of genetic testing results. And we always like to warn people about this beforehand so they're prepared. You could be positive, meaning that we could detect a mutation, which is that misspelling that I spoke about before, in a gene that we think would put you at increased risk for cancer. All of your testing could be completely negative, which is a good thing, which means that all of your genes look like they have normal signatures and should work. Or the third category is what's called a variant of uncertain significance, or VUS. And this is very, very important because it gets very confusing. And this means simply we don't know. And we acknowledge that. It means that the way that your gene is spelled is rare. And we're not sure if it's something that is potentially misspelled that could cause cancer, or if it's just a rare way of spelling the word, like how sometimes the British people spell words a little bit differently. What I tell my patients is it's like hair color, right? There's variation in hair color. Brunettes might be a little bit more common. You see some blondes, but if you have never seen a redhead before, you don't know, is that weird? Is that associated with disease? But then as you meet more redheads, you realize, oh, this is just a different color that's rare. And so that's exactly what these VUS findings are. They're just rare findings. And because we haven't tested everyone in the world, we don't know all of them yet. But as we test more people, they get reclassified. And over 90%, the vast majority end up becoming negative or benign or normal. And only a few actually are associated with cancer. So that's why it's really important not to do anything based on a VUS, especially not to have a big surgery or something drastic like that, because most of the time these end up becoming benign. And it's really important because studies have shown that it's more common to have these VUS findings in people of non-European ancestry, just because a lot of the testing traditionally has been done in European populations. And we just need to catch up with the rest of the world and test more diverse people, which we're definitely doing, but things like that take time.
So if a patient gets genetic testing and that's their result, it's sort of like a wait and see approach for the most part.
Exactly. If they have a
Right.
VUS finding, we spend a lot of time kind of talking them through this, and then we say, you don't need to do anything, but we have international databases that track these, and we tell patients, just check in with us every few years. It could be just a quick phone call or a message on the portal, and we'll let you know if there's updates. And if there is a formal update, the laboratory where you had your genetic testing should notify you. Of any changes to the classification. So I always tell people it's sort of a limbo finding. It's a hold, and we need to wait for more information.
Great, thank
Yeah, and
you.
Maggie, I just want to second that point that Dr. Liu made earlier, that we really, in terms of doing anything major, treat these as negative, because as she said, we really don't know if they're meaningful or not. And so in my case, for example, with breast cancer, I have lots of patients who have VUSs in genes that put you at high risk for breast cancer, to the point where we would consider doing what we call a risk-reducing mastectomy. And in those cases, we really don't make that decision or that recommendation based on a VUS, just because it's not something that it's not a known, a certainty that you have definitely a mutation that is going to cause a problem in the future. So we really don't act on these surgically.
Great, thank you. And then one area of confusion that there often is around genetic and genomic testing. So I'm wondering, Dr. Moo, could you sort of briefly explain the difference between the genetic and genomic testing?
So for our purposes, genetic testing, we're looking for basically inherited gene mutations, and we're often looking for testing for specific genes. As Dr. Liu mentioned earlier, most of the genetic testing that we do is a multi-panel testing, and you're looking for specific mutations that are known to us to cause an increased risk of breast cancer or colon cancer, ovarian cancer, etc. And that's usually the genetic testing that you'd have when you meet with a counselor, and they send off your blood work or your saliva to look for this testing. Genomic testing we use mostly in the context, I think of it as for the tumor, having more information about tumors. And so we basically do DNA sequencing of the tumor to see which genes are upregulated or downregulated in the tumor, and which genes and how, and we have actually developed tests that will actually turn this into a predictive model to tell us how likely is that this tumor to behave badly in the future, and also to inform our decisions around treatment. So do we have any medications, or in my case in breast cancer, it'd be like, should I give this patient chemotherapy, or should we recommend chemotherapy for this patient based on the findings of the genomic testing of the tumor? So that's the context that we often use it for in breast cancer. I don't know if Dr. Liu has anything to add to that.
That was a great explanation. I will just say that the two worlds are overlapping more and more, in that the results of genetic testing, meaning genes that run in the family like BRCA1 and BRCA2, are also now affecting treatment. For example, in breast cancer and in ovarian cancer, which is a type of cancer I treat, having these inherited mutations in BRCA1 or BRCA2 could make you eligible for certain therapies like like PARP inhibitors or things targeted for these genes. So now, in addition to doing genetic testing to prevent cancer, it actually is affecting your treatment options. So it's another reason why we're doing this. And at MSK and other centers around the nation, many people are doing this simultaneously. So doing both types of testing together.
Mm-hmm. Great, thank you. And Dr. Liu, you started to talk about, some of the genetic mutations, but I'm wondering if you could speak a little bit more about some of those mutations that genetic testing could find and what are the implications of that?
Absolutely. So I think the most common genes that people are aware of are BRCA1 and BRCA2, which are associated with hereditary breast and ovarian cancer classically. We're actually learning that the cancers associated with these genes are broader than just breast and ovarian cancer. We're learning about connections with prostate cancer in men, pancreatic cancer in all people. I study endometrial cancer. We're learning about connections there. There might be connections to gastric cancers, melanoma, so that the list is kind of going on and on. And then there are genes in that pathway, so that do similar things. One that's been in the New York Times and the press a lot is something called PALB2, which people might not be aware of. It's actually a partner for BRCA2, and it's very relevant for breast cancer. The risk of breast cancer with PALB2 is getting close to that of BRCA1 and BRCA2. So we often think of those together. And then there are sort of other genes that we consider more moderate risk. So not as high risk of breast cancer and other cancers, but still higher than the average woman. These would be things like CHEK2, ATM. And then the other sort of category that people may have heard of is something called Lynch syndrome, which is one of the most common genetic syndromes associated with cancer risk. Classically, those are associated with increased risk of colon cancer, endometrial cancer, but we also are learning about other cancers like pancreatic cancer, other GI cancers, bladder, and those types of cancers as well. And the reason Lynch syndrome, I think, has been in the popular press a lot is because of new types of therapy called immune therapy that target the special type of tumors that we see in Lynch syndrome. Just because of the way Lynch syndrome works, those tumors have a lot of mutations, a lot of changes in them. So I think those are the most common syndromes and genes that people might be aware of.
Great, thank you. And Dr. Moo, I'm wondering if you could talk a little bit about some of the ways that the results of genetic testing can be used by a patient.
So I think probably the more immediate use of the genetic testing is to determine if you are positive for the gene, as I said before, how you would be screened. So, or is it a gene that we can screen for the cancers that it causes? So in terms of the BRCA gene, we are able to screen for the breast cancers, and to a more limited extent, and ovarian is very difficult. We do ultrasound, but not as effective as breast cancer screening. But we would start screening based on those results. The other thing we would do is discuss prevention. So there are certain preventative surgeries that we can do when you have a mutation. And I keep referring to breast because that's my specialty. But in breast cancer, if you have the BRCA gene, we would talk about preventative mastectomies, so bilateral prophylactic mastectomies, and what the implications of those are. These aren't things that you have to do, but things that we definitely discuss and tell you what your options are, whether it's going to be screening, high-risk screening, or preventative mastectomy. There are also medications that you can take as well to reduce your breast cancer risk. So we would, when somebody comes in with a mutation, I sit and I go over all of those options with them. Also, it affects your family members, right? So this is for these genes that are hereditary mutations, then you would think about, well, who else in the family needs to get tested? And that's something that I think Dr. Liu would is very familiar with, because you're usually telling the patients where who should get tested, but it does have implications for your family members as well.
Great, thank you. And then we're talking a lot about genetic testing, obviously, but there are, some hesitancies people have, or, wondering, if it's safe. So I'm wondering if we could just delve into some of those types of questions. So Dr. Liu, the first and foremost, is it safe to get genetic testing? And, what's that process like?
Absolutely. So it is very safe. So the actual process itself is not very invasive. We need a sample to test your DNA, and that could be through blood work or saliva. So you could spit into a kit and send it to the lab, and they can extract the DNA from that. I think a lot of what people worry about is privacy concerns, of course, which is very, understandable. So any type of genetic data like this from genetic testing is subject to the highest levels of protection and confidentiality at all labs and in all centers. So this information is protected very carefully, and it can only be shared if you, the person whose data this belongs to, allows the facility or the lab to share it. A lot of people ask, well, is my employer going to see this? Is my health insurance going to see this? Are they going to discriminate against me? And there's actually the GINA Act, the Genetic Information Non-Discrimination Act, that helps to prevent that. And so we go over that with people. And the other thing is, people say, well, is this accurate? Are they going to mix my sample with someone else? And these are definitely real concerns, and we take them very seriously. That's why genetic testing can take up to 2 to 3, sometimes even longer, because there's a lot of quality control built in. And we always offer to people, if there's a positive result that comes back and it's going to be life-changing for you, of course we can double check that. We can test you with a different sample in a different lab. So there's a lot of different things that we can do to help people feel more safe and comfortable about genetic testing.
Great, thank you. And then I think you covered the safety and the confidentiality piece, but what about the cost? Is it expensive? Is this something that insurance is going to cover?
Thankfully, with technology getting better, the expenses is much better. So insurance is covering a lot more of genetic testing, and this is directly tied to our guidelines, and that's why they continually change. And we really try to advocate for our patients and find a way to get insurance to cover it. In the event that insurance doesn't cover the testing, a lot of the major labs in the nation have what we call direct-to-consumer tests that are severely discounted. I mean, it's still a couple $100s, but it's better than the couple $1,000s it used to be. That may still be prohibitive for people, and there are definitely a lot of programs and through MSK as well that help both cancer patients and non-cancer patients get genetic testing. So I think as time has gone on, the cost has definitely gotten better, and I hope that's what people are experiencing.
Great, thank you. And then, the results of genetic testing can obviously be a really sensitive subject. So Dr. Moo, I'm wondering if you could give some advice on how people could talk to their families about, positive findings from a genetic test, and, what family members should they be letting know about that result?
So I think, it is a very sensitive topic. It's like, deciding to how you're going to talk to your family members about a cancer diagnosis, for example, and sometimes it could be even worse. But I think you really have to think about the real implications for that, for the rest of your family also, when you're thinking about this, so that you can get over that sort of hard part of the conversation, because in the end, I think knowledge is power, and your family members having the opportunity to have that information and make the decisions regarding screening or preventative surgery is a good thing to do. So it really is difficult. But depending on, usually it's your immediate family members, your sisters, for breast cancer, for example, it would be your sisters, your daughters, your mother, if she isn't tested, people who it would directly impact, and you may not always know those people. But those are the questions that you can ask your genetics counselor when you're getting these results. Who do I need to tell about this? Who else needs to get tested? And they will actually point you in the right direction. But I really think it's something that you should share with your family members, because they could be affected by the same genes as well.
Great, thank you. And that's a good transition to now invite Nefa-Tari Moore into our conversation. So Nefa-Tari, you have such a unique perspective on this topic. You're a patient who underwent genetic testing. So I'd love for you to introduce yourself to our audience. And then, before you delve into your personal experience, is there anything we've discussed so far that you want to comment on or think that we haven't touched on yet that would be important?
Yes, thank you. Hi, everyone. My name is Nefa-Tari Moore, as Maggie just mentioned, and I am the Outreach and Uterine Program Coordinator at Share. And yes, I'm a person who had genetics testing through ovarian cancer diagnosis. But I do have a couple of questions for both Dr. Liu and Dr. Moo. My first question would be, can men pass it out, being that we get a pair of genetics from both parents, can men pass down genetic mutations as well?
Absolutely. This is a great question. And yes, and that's where it can sometimes get confusing, because sometimes I speak with women who find out that they have a BRCA mutation, and it comes from their father, and their father only had brothers, and it's just a lot of men on that side. And they tell me, we don't have breast cancer on my father's side. Where is this coming from? And so absolutely, that's why it's really important for not just women to get tested, for men too, for their daughters and also for their sons, because we're learning about associations with cancers like prostate cancer that affect men. And then Dr. Moo knows more about this than me, but there are men that get breast cancer, and having, for example, a mutation in the gene BRCA2 does increase the risk for men to have breast cancer. So I think that's important for them to be aware of as well.
Yeah, that's absolutely correct. And, actually having a male breast cancer diagnosis is something that triggers genetic testing for us. Just having the diagnosis of a positive mutation in terms of breast cancer doesn't necessarily change your screening, but as Dr. Liu says, it does change testing for, say, your daughters or your sisters if you're the male who tests positive. So testing is definitely important, because they can harbor the genetic mutation.
Thank you both for answering that question. Just have one other question. I think earlier Dr. Liu may have mentioned about the genes and what those letters mean, and being positive for a genetic mutation. Do those proteins ever change with treatment or surgery?
This is a great question also, and we get asked this a lot. So this is where we have to differentiate genetic testing of your blood to look for genes and changes in those genes that you were born with, that were passed down from your parents, versus testing of the tumor and the changes in your cancer that may change over time and are what are causing the cancer. So when we talk about genetic testing for what we call inherited or family risk, these are the genes that you were born with. So if you were born with this spelling that is misspelled in your BRCA1 gene, you will always have that. That is present in every cell of your body. If you then develop breast cancer in your breast tissue, those cells will look different and will also have changes or mutations, but they might be in different genes, and those might change over time depending on, treatments and resistance and so on. But the genetic testing part, that BRCA1 that you were born with, will never change. And sometimes people ask me, well, I had genetic testing a few years ago, and I was negative for the BRCA1. Do I need to get it tested again? And I say, no, you don't need to get it tested again, because if you were negative before, it'll still be negative. But the caveat to that is sometimes people do need updated testing or genetic testing because we learn about new genes, and maybe their prior testing only had the BRCA1 and BRCA2 genes and didn't have the newer genes like the PALB2 or other ones that I talked about earlier. Or they had their testing long ago when our technology wasn't as good, and maybe it didn't cover all of the genes. So even though for the most part, people who have had genetic testing once probably don't need it again, we do see women with breast cancer, especially, or a family history of breast cancer, who may have had testing really early on when we didn't know about that many genes, when the technology wasn't as good. And we actually do have them come in again and get updated testing. So that's something to be aware of. If your testing is more than, I would say if your testing is before 2015, it might not have all of the newer genes, and it might be worth a conversation to see if you need to get updated testing, not of the same genes again, because those don't change, but to cover the newer genes. Does that make sense?
Thank you. And one last question I'd like to ask in terms of the cost. If you have enough people who are closest to you diagnosed, let's say maybe, enough siblings, or, maybe an aunt or someone, if at any point does it, the genetics testing become free of cost for those people?
That's a great question. So many companies that do genetic testing, if someone tests positive for a finding, because it's so important, they will for free test family members. So it's always, important to ask, your counselor or the lab or whoever's ordering your genetic testing, if that's possible, because a lot of companies do that.
Thank you.
Great. And Nefa-Tari, I know that, you have personal experience, so I don't know if you would maybe mind sharing a little bit of your story and, what genetic testing was like for you, and, having those conversations with your family members.
Well, yeah. Well, I mentioned earlier that I was diagnosed, I had genetic testing through an ovarian cancer diagnosis, but before, getting my diagnosis of ovarian cancer, I had a uterine cancer diagnosis. In 2013, I was diagnosed with uterine cancer after experiencing, some heavy bleeding, and yeah, I went on like hormonal treatment, for about, 9 months or so. And then at some point I became MED, evidence of disease. And so I was in surveillance for, I had biopsies every 3 months because during my initial diagnosis, I didn't have surgery because I had just gotten married 5 months prior to receiving my diagnosis. So we were planning to, make a family together. And so it was because of fertility preservation that I didn't have the surgery. And so every 3 months, because I still had my uterus, I would go in and have a biopsy. And so during the third biopsy that I had a recurrence. They found a recurrence of endometrial cancer. And so at that point, I did have surgery. I had only my uterus removed. I had a partial hysterectomy, and I was left with both ovaries and fallopian tubes. And so I was in surveillance still. And each time I would, get to, the 6 month point before, and then hoping and praying to get to that yearly, appointment or surveillance of being NED. But unfortunately, I never made it to that point. In 2015, I believe, I was diagnosed. That's when I had the recurrence of endometrial cancer and had the partial hysterectomy. So I was still in surveillance, hadn't had genetics testing yet at that point. I did ask about it, but I was told that I didn't need, genetics testing. There wouldn't be anything associated, with my diagnosis. But then I got a different oncologist, a new oncologist, and in 2018, I went in for a routine checkup and had transvaginal ultrasound, and it showed that they suspected that I had ovarian cancer. They wanted me to come in, at that time, a very busy working schedule. So I, taken a day off and, had my, went in for my appointment, and, I got home and my phone rang like right away. So I knew it was something, before I even answered the phone. So when I answered, and I just told the doctor, just give me, the news, don't beat around the bush, just give it to me straight. And so she wanted me to come in for a CAT scan to have a closer look because, as I said earlier, they suspected that may have been ovarian cancer. And it turns out, that it was. And then I had to have surgery to remove my ovaries, fallopian tube, and everything else in that, reproductive area. And was told that I had to have 6 rounds of chemotherapy, carboplatin and paclitaxel. And then I was asked, have I ever had genetics testing? And I told my oncologist, I said, no, I've never had it. She was kind of surprised in a way, but she did send me to see a genetics counselor, right away. But I didn't have the testing until after I completed treatment because they wanted to move fairly quickly. And so, yeah, I completed the 6 rounds of treatment, and for me, by the grace of God, it came out NED. Still to today is almost 5 years since. In July it'll be 5 years since I've been NED. And I had the genetics counseling testing rather, and it did come back that I have Lynch syndrome. I didn't know what Lynch syndrome was in a genetics counselor. She explained it to me. I didn't know really at first how to tell my family, but I knew I had to say something, because I have, several brothers and sisters and nieces and nephews as well. And so, as it was mentioned earlier, how some people, this is breast cancer or this type of cancer doesn't run in my family. Cancer didn't run in my family at all. At least I didn't know at the time that anyone in the family had cancer. So I wrote a letter, in fact, to my sister, just explaining, some things to it. And I sent it through the mail, and her mom was the one who got the, the letter, and she opened it, and, a lot of, we had different moms with the same dad, but in a lot of Black families, our moms open our mail. So, so her mom opened the mail and she read the letter, and she called me. She was the one to call me, and we talked about it. And then she told me that my uncle, my father's brother, he had died from colon cancer. And so, um, yeah, and so I, went over to my sibling's house and we talked, a lot about the cancers that I had had, because even with being diagnosed with uterine cancer twice, I had never said anything. I didn't tell them about the cancer, but I felt I had to with the ovarian cancer, simply because I was going to, go through treatment. Life was going to be different for me. So, yeah, I told them, and none of them, thank God, haven't been diagnosed so far with cancer. But then at a holiday party, I was talking to a great aunt of mine's, and she herself had had breast cancer, and her mom, which was my great grandmother, she died of ovarian cancer. And then there were like other uncles and cousins and things like that that had been diagnosed with colorectal cancer. And so I was just finding out that, and this is all on my dad's side of the family, that now all of these people I'm finding out have had cancer where I didn't know, you know. But, I was able to take that information and share with my care team. And so, if in case, God forbid, if I ever be diagnosed with any other type of cancer, this is good news for them in a way that, they can help, treat any new diagnosis or recurrence that I may have, in the future. So it kind of made sense to me, and it may sound weird, but I was kind of glad that I found out that I had this genetic mutation, because I kept questioning myself, like, why, do I keep, getting these diagnoses, being diagnosed with cancer? So, it made sense. And then it also, let the family know, as I said earlier, I have several nieces and nephews, just in case anyone and, any one of them were ever to be diagnosed, they know that they had this aunt, and now they have a grandmother and great this person and that person with this cancer. So it just, it's just more information for my family, and it's something that we can, now talk about. Our conversations don't center around it anymore, or at all, but it's, we all know. So it was very helpful. I am in surveillance every 6 months, and I'm, under the understanding that I'll be in surveillance for the rest of my life, because I do have just this genetic mutation. And so, that makes me feel better, because I know that if anything if I were to be diagnosed, it would be, caught early. So, yeah, but I'm doing well today, and I'm just, happy about that. Living a very joyful life after being diagnosed with cancer 3 times. And I just want to say thank you for having me.
Yes, thank you so much for sharing that with all of us, and really giving context to the discussion that we've been having with Doctors Liu and Moo today, and how you went through that process and having those conversations with your family. So thank you, Nefa-Tari, and thank you so much, Dr. Liu and Dr. Moo, for answering all the questions we've gone through so far. We have a little time for Q&A, so I'm going to quickly shift gears so we can try to address some more questions. And one thing I realized that we didn't get to earlier, which has come up a bunch, and I just want to make sure the audience knows, is if you have that information, at what age is it appropriate to get the genetic testing?
I can take this one. That's a great question, Maggie. And Nefa-Tari, thank you so much for sharing your story. And it brought up so many points that we talked about tonight. That cancer in the family is not something people talk about at the Thanksgiving table or around the Christmas table, right? Across all cultures, I feel like there's a lot of taboo around talking about cancer and kind of suffering in silence. And you're not the first person to tell me that when all of a sudden there's a genetic syndrome diagnosis, and now you're telling family members, they're now telling you about all the cancers you never knew about. And that's something we've recognized in the community, that a lot of our guidelines are flawed because people don't talk about the cancer. And now that we're testing more people based on rather just their cancer rather than family history, we're learning that we missed people. And just like I see some questions in the chat, 10 years ago, we didn't think that there was that much of an inherited component to endometrial cancer. Testing was not as uniform. Ovarian cancer, we knew more about. So I think that's why the testing came a little later. But that's why, events like this and sharing your story is so important, because we're trying to make people more aware of this type of testing. And now, Maggie, I've forgotten your original question.
That's okay. It just the age at which
Yes.
people should,
So obviously, if your children are young, this is a lot, right? And so age of when to do testing is very important. And in the genetics community, we sort of feel that the age to do testing depends on the gene, the cancers that you're at risk for, and what age you would start to do something to prevent them, right? So for the genes that we've been talking a lot about tonight, like BRCA1, BRCA2, we usually recommend testing around women around age 25, maybe a little bit before, because that's when you would start the screening. We don't want people, tested before they're adults. We don't want to cause too much anxiety. But other syndromes and genes like Lynch syndrome, we test earlier because we do colonoscopies earlier. And there are other more rare syndromes where sometimes the cancers happen in childhood. So we actually do test children. And I have colleagues that work on the pediatric side. So I think it differs a little bit, but in general, for most of the genes that we're talking about and the ones related to breast cancer, we usually wait till people are in their 20s and adults, and then can make their own decisions about this.
Great, thank you. And so I'm looking at the time, and we packed a lot in, and I'm just hoping that maybe to close, if you could each share sort of one takeaway that you would love for everyone watching today's webinar. Like, what's your key takeaway for everyone? And I'll start with Dr. Liu.
Just start the conversation. Just get talking about it. Don't have to commit, but talk about cancer in the family, talk about genetics, because it doesn't just affect you, it can affect your family, and starting the conversation is the first step. Great,
thank you. Dr. Moo?
And I would say, again, just go ahead with that testing if you are recommended for it. I know there's often a lot of fear around it, especially being afraid of, well, what are they going to recommend, that I take my breasts off? Or, there's a lot of fear around getting those results and living with those results. But as Dr. Liu said earlier, I'll steal a line from her: knowledge is power. You then have the ability to screen or to do something preventatively, even if you decide that you're not going to do surgery. That's not always the only option. So go ahead and get the testing so you have the knowledge.
Great, thank you. And Nefa-Tari?
I would just say, have the testing, because it will, open up so many things and ways for your particular diagnosis to be treated, and for the future, if anyone else in your family were to be diagnosed, it would be helpful.
Great. Thank you. Thank you so much to our three panelists today for sharing all this information, and especially Nefa-Tari. Thank you again for sharing your story and your experience and what you went through. And thank you to our audience for joining us today. I hope this was an informative conversation for you. We will be sending out an email afterwards with some resources, so please be on the lookout for that. And there will also be an evaluation that'll be sent out, so please fill that out. We use that information for future program planning. And yeah, thank you again for today's great program. Bye, everyone.